Welcome to your first lecture in your pharmacology class. So today I'm basically going to give you a brief overview on things to consider when prescribing, and then we'll go over kind of the nitty-gritty of pharmacokinetics and pharmacodynamics, which is what I have here for our overview. So basically, in a nutshell, pharmacokinetics is what our body does to the drug, so us absorbing it, distributing it throughout our body, us metabolizing it, and then us excreting it. And then pharmacodynamics is the effect that the drug has on our body. So first of all, just going over some things to consider when we're prescribing. We do want to make sure that we have the right patient. So if the patient's in front of you, then that's kind of obvious. But if say you're reviewing somebody's lab results and realizing they need a prescription, then that does come into play for making sure you're prescribing to the right person, right drug, right dose, right route, making sure all of those things are clearly spelled out when you're writing out a prescription. You're also ensuring that there aren't any contraindications for them taking the drug. You're considering their allergies and intolerances, and making sure you're differentiating between those. You know, if somebody's having some diarrhea or some nausea from an antibiotic, that's more an intolerance rather than actually a true allergy, but taking those pieces into account and what their sensitivity is like. Any kind of drug interactions, so what supplements are they taking, food, other prescriptions, part of that goes into patient teaching as well. And Hippocrates is a great tool for you to be able to check for drug-drug interactions, as well as drug-food interactions. So knowing how to use your resources well is half the battle. We're also thinking about side effects. What's the convenience of the drug we're taking? You know, maybe it's more effective if we take it 4 times a day, but then if you prescribe it as 4 times a day, they're not going to take it. So maybe it would be better to choose once a day or twice a day medication. So taking those factors into consideration. Route of administration, storage, you know, do they need instructions on making sure that it's kept in the fridge, and then any kind of special patient considerations, whether that's that cultural beliefs, health beliefs. I think about that with antibiotics quite a bit, pregnancy, breastfeeding, etc. Patient pressuring the prescriber can be a big deal, whether that's you know, patients coming in saying, hey, I saw this on TV, this is the one I think I want, versus I definitely need an antibiotic, or I definitely need an opioid, something like that. So just to be aware that we have a little bit of an uphill battle climb for this. The prescription companies are advertising almost as much to them as they are to us. So considering that as well. And then cost is definitely an issue. Sometimes we pick the second best medication because it's affordable. And I think your awareness of your environment and your patient population, taking each patient into account individually as well. But like, for instance, Walmart has a $4 list where they have a certain number of prescriptions that are always going to be $4. And if you can get one of those, if it's basically the same as far as how well it's going to work, then that can make a big difference for patients sticking with their routine. And then also thinking about generic versus brand names. Generics are going to be cheaper versus brand names. We're going to trust the product more. Maybe certain kinds of medications we're fine going generic, and other ones where perhaps it's a really narrow therapeutic window, we're going to want it to be more specific and trust the dosing more specifically. I'm sorry, I've still got laryngitis here. Okay, socioeconomic factors, insurance, income, daily schedule, literacy, support systems, all of those come into play. Previous therapies. I think of this especially for birth control. Okay, what have you had in the past? Did that work well for you? Did you remember to take your pill every day? That kind of thing. Or even antibiotics. Oh, that big horse pill, as soon as my symptoms were gone from my UTI, I stopped taking it. you know, okay, well, maybe we could pick a different antibiotic this time to help encourage people to go through their full dosing. And then we have adherence, which I've already touched on a few times here. But many prescriptions are never filled, so that would be worth assessing and documenting and tracking within your practice too, and just something to consider. Just because I wrote a prescription doesn't mean they're going to fill it, doesn't mean they're going to take it how I recommended they take it, etc. So making sure that we're really involving patients in decision makings for their care can help improve adherence as well. Barriers to medication adherence could be complexity of the drug regimen, cost, multiple prescriptions, issues with polypharmacy, side effects being too much, significant cognitive or physical impairments. So all of these pieces are going to play a role in there. Great. So I just want to, I'm just barely touching on this, but I think this is a really important slide, and is probably one of the things that new grads find hardest when they first graduate. Is you're used to thinking in school, okay, what would be a good medication for this? But then you're not thinking about, okay, how would I exactly write this out? Or do I have the dose in my head exactly right? So a lot of practices here in the Twin Cities will have electronic charting, where it's just really self-explanatory and a little bit hard to go wrong. You're entering in the computer what you're needing, and it's pulling up for you recommended dosing, and you're just sending it right on to their pharmacy. So really lickety-split. Other ones, you might have your nurses calling in prescriptions for you. Other practices, you might call it in yourself to the pharmacy. Other practices, you might write out a prescription on a pad and send that with patients on their way. So regardless of which way you end up sending it to the pharmacy, there's a certain number of elements that need to be there in order for them to process it. And we don't want guesswork. So first of all, your clinic's name and phone number and address need to be accessible. If you're calling in a prescription, usually they don't need the address, but at least a phone number. So like if you're leaving a message for what prescription is going to be called in, if they have a question about it, they know who to call in order to have that clarified. So they need to know your clinic and your phone number, and then your name needs to be on here somewhere, along with ultimately your NPI number. And then if you are calling in a like an opioid, then you would need to have a DEA number. Any kind of controlled substance, you would need your DEA number on here as well. So yep. So you'll have those, and then patient's name, date of birth, address, date. Sometimes these will have a phone number on here. If you call it in, they like to know patients' phone numbers, because then they can call the patient in to let them know their prescription's ready or whatnot. So then for filling out the part about your medication, you need to have the medication and then what it is you want dispensed. So in this case, I want metronidazole, and I want it to be 500 milligram tablets. So I put that first, and then I put SIG, which is then where I'm going to write instructions. So take one tablet by mouth. So I've got how much, what my route is, twice daily for how often, and then that duration continues for 7 days. And then I'm putting how much I want in the bottle, basically, which in this case would be 14 tablets. So put dispense 14 tablets. Or even if you just write the number and circle it, 14 tablets, that would work as well. So that needs to be on here as well. And then for refills, I've just circled no refills on here. So if you're calling it in, that's how you'd read it. I'd like to prescribe this for my patient. It's metronidazole 500 milligram tablets. Instructions are to take one tablet by mouth twice daily for 7 days, and I would like 14 tablets dispensed, no refills. And that would be how you communicate that part of it. And then typically there's two different places you could sign your name. One would be if it's fine to put a substitution, and then the other one would be if you want it to be filled exactly how it's written here. So if they did have a generic substitute and you were fine with that, that it would be a lot cheaper than if you just sign on that area, then they'll just do that automatically for you. If you are doing a medication that's ongoing, you might want to think about how much you want to dispense. For example, with some birth control pills, for example, I might dispense 90 days worth. So 3 pill packs, and then they only have to pay their copay every 3 months rather than every month. So there's different ins and outs for that, and once you get kind of settled in a community, you'll figure out even just what contraceptive pills that local pharmacy stocks, and what the cheapest ones tend to be, and that kind of thing. But a lot of that depends on people's insurance companies as well. So I know for myself, I've always found that to be a little bit of a steep learning curve. But even just flexibility, sometimes not leaving a message for the pharmacist and rather talking to one over the phone, you can figure out a better medication based on what kind of patient preferences you're wanting to address. Okay, so basic definitions then. We're getting into the pharmacokinetics and pharmacodynamics piece. So this lecture only covers the first 2 elements of this, but I did go ahead and give you definitions for the final 2 as well that you'll be reading about. So pharmacokinetics in a nutshell is what our body does to the drug, and then pharmacodynamics is why we're taking the medication in the first place, so how it interacts with our body tissues to get us the therapeutic effect that we're looking for. And then pharmacogenetics is basically how based on people's genetics that can really affect how medications are metabolized, how quickly it gets through their system essentially versus it building up, and there can be a lot of variability there. So I'm going to touch on that briefly, but for the most part that'll be in your other readings. And then pharmacogenomics is just the constant development and use of medications. Okay, so pharmacokinetics, we're looking at absorption, distribution, metabolism, and elimination. So we're going to go through each one of these. So for drug absorption, weak acids and weak bases. Most medications would fall under one of those categories. Acidic drugs tend to absorb better, especially when they're in their unionized form. It makes them more lipid soluble, and we need to be lipid soluble in order to get through the cell membrane. So you can see here, this is a villus within the intestines, and any given villus is going to have all these tiny little microvilli on it too. And in order for a drug to be absorbed, it needs to be able to absorb through the cells here and then through the membrane of the artery or vein. Right, so in this case, to get into the artery. So we need to be able to cross through cell membranes, and cell membranes have that phospholipid bilayer. So being lipid soluble makes that part easier. So if drugs are a little bit more basic, they tend to be more water soluble, and that can be a little bit trickier. But then it also depends on the environment. So like your stomach is more acidic than your intestines. So certain drugs are more apt to absorb readily in the stomach, whereas other ones, once it gets to be a little bit more basic in the intestines, that's where it will absorb well. So aspirin's a good example of that. Aspirin's pretty acidic, and it will absorb really quickly in your stomach. Okay, so again, water soluble, lipid soluble, we already talked about that with the phospholipid bilayer. And then the less of a charge there is, the easier it will absorb as well. So that's where that unionized piece versus ionized piece can play a role too. So if you don't have a charge, it's going to be absorbed more easily. So passing via the plasma and cell membrane. So that's what we talked about over here. That can be active or passive transport. It can depend on the absorbing surface, but it does need to pass through cell membranes. And your ileum is where you have the most surface area. So that's the number one absorption factor, would be how much surface area is there. That's going to affect absorption the most. So just to think about a couple of the most common routes we have for medications. So pros to taking medications by mouth. It's safe, it's inexpensive, it's relatively convenient. Cons can be that since it has to go through multiple different avenues before it can get to our target tissue, there can be a lot of differences from person to person. So based on your age, that can affect your gastric pH as well as what your normal diet is and your normal health. GI flora is an interesting topic that's coming out more and more for it's not just about how our bodies interact with medications, but also how the flora in our bodies interact with those medications and can speed up them getting metabolized or absorbed, or it can interfere with their absorption or metabolism. So I won't get into that a whole lot, but that can definitely alter absorption, and then how quickly people empty their gastric emptying in presence of foods. Limited absorption due to chemical properties like solubility, gastric enzyme destruction, gastric irritation that can lead to side effects. All of those things are going to affect how oral medications are able to be absorbed, as opposed to, say, if you just put it right into their bloodstream via an IV. Enteric coating is worth mentioning here as well. So basically, a lot of medications will have some type of a coating to see if they can get it through the stomach so that the enzymes in the stomach don't completely break it down. But some will have multiple layers of coatings. Think about, especially with sustained release tablets, that's designed so the coating comes off and you have a little bit of drug, and then there's another coating and a little bit more drug, and that can be nice for having a slow, uniform absorption. And then it can get past the stomach to avoid the gastric epithelial irritation too, so the effect that it can have side effect wise. Okay, and then first pass effect is only going to apply to oral medications. So basically, after food as well as medications are first absorbed into the bloodstream from the intestines and from the stomach, they're going to go through the liver first before it ever reaches its intended destination for the therapeutic effect. And in going through the liver first, it can start to break down the medication in its excretable form, and in so doing, we've lost some of its therapeutic value. So that first pass effect would just apply for oral medications because the liver gets a shot at it before it can reach our destination. So that can affect essentially initial dosing. I think a good example of that is estrogen. The liver really does a number to estrogen, and so because of that, if you're taking estrogen by mouth, it tends to be a much higher dose in order to make up for that first pass effect. Okay, so then just thinking about a couple things related to parenteral routes. So IV, IM, sub-Q tends to be more rapid, though that depends on how the medication is developed. It can intentionally be developed to be slower. So I think insulin's a good example of that. But it tends to be a little bit more predictable drug absorption because you don't have to account for all of those GI factors as well as the first pass effect. And then typically it's just absorbed then by diffusion rather than all the different routes if it was in the intestines. But regardless of the route, what we're most concerned with is bioavailability. And so when medications are produced, they're produced with the hope that we're aiming for like a certain concentration, plasma concentration in the blood, in terms of how much of it, after whatever route we got there, how much of it is actually available for the body to use to reach its therapeutic purpose. So drug distribution factors, so we're absorbed and now we need it to get it where we need it to be. So factors that can affect that would be the size of the drug molecule, and then its affinity for aqueous versus lipid tissues. So sometimes, like certain medications will particularly have an affinity for lipid tissues, and then it will just start storing itself up in fat tissue and it's not getting where it needs to go. Tissue permeability plays is a factor when we think about drug distribution. And then the systemic circulation, and then protein binding and pH. Protein binding is a pretty big one, and I'm going to touch on that again in a couple of slides, so we'll come back to that. And then pH can also affect its ability to be distributed. So when we think about distribution, it's helpful to think about having a steady state. These are the main terms we think about: steady state and a half-life. So a steady state is achieved after 4 to 5 half-lives, while elimination takes about 4 to 5 half-lives. So I want to spend some time thinking about this, because this really does impact quite a bit when we think about how much we're dosing, how frequently we're dosing, and then if we're tapering people off, what to expect for that as well. And also thinking about, how quickly when somebody starts to take a medication, do we expect it to reach its therapeutic effect? So the steady state is the rate of drug elimination equaling the rate of availability. So you can see here, every time there's a little point, that's when we took another dose. So we started out here, we took another dose, we took another dose, and then by the time we're about here, we're staying even keel as far as how much is in our plasma, how much of the medication is in our plasma. So how long does it take to reach a steady state would be something to think about. And then half-life would be the amount of time it takes for the plasma concentration of the drug to be reduced by 50%. So I'm actually going to go to the next page, and we're going to think about exactly what that looks like. So say we have a patient who's been taking Zoloft for about a year, and she's decided to stop taking her medication, which I wouldn't recommend stopping cold turkey as an aside. But the question is, how long will it take for the majority of the drug to be eliminated from her system? So that all depends on what the half-life of Zoloft is. So in this case, for women, the half-life of Zoloft is about 34 hours. So at present, we have 100% of our normal plasma concentration, so that's our steady state. We've reached it, we've been there for a year. So after 34 hours go by, we expect half of it to be there, so 50%. And after another 34 hours go by, we expect half of that to be there, 25%. And another half-life, half of that, 12.5%. And you can see we end up with about 170 hours, which is about a week, when we reach 3%. So when we say it takes about 4 to 5 half-lives for it to be out of their system, you can see it'd be a pretty big difference if somebody has a day-long half-life versus a 2-minute half-life, how quickly it takes to get out of their system. So you're doing the half-lives. So I hope that makes sense. But then the same would be true for reaching a steady state. It's going to take 4 to 5 half-lives to get up to the level we need to get up as well. So, say we're going to change her dose, I would want to give it at least a week at the dose we changed to before considering changing it again, because we're not reaching our new steady state until it's been in our system for about a week. It doesn't matter if you start super high at a super high concentration or whether you're starting out at a low concentration. It's that same concept of whatever you have, half of that, half of that, half of that, 4 to 5 half-lives, and you're less than 5%. Okay. Yeah, so then just to think about for comparison, Prozac's half-life is about 2 to 4 days. So while it takes about a week to reach a steady state for Zoloft, it would take about 1 to 2 months to reach a steady state for Prozac. And then for Pitocin, the half-life there is 3 to 5 minutes, which we're thankful for if, say, we have a postpartum hemorrhage. It's 3 to 5 minutes via IV. So if we have a postpartum hemorrhage, needing to get up 4 to 5 half-lives worth before we're reaching our steady state, we can get there quite a bit quicker. Because the half-life is so short. Okay, so I said we would come back to protein binding. So we have a lot of different proteins in our blood, the main one being albumin, though there are others, and a certain percentage of the drug at any given time is going to be bound to proteins. So the amount of the medication that's actually useful and it's serving its therapeutic purpose is whatever amount isn't currently bound. So say somebody just came out of surgery, or they have rheumatoid arthritis, that kind of thing. They'll generally have quite a bit more protein running through their blood than other times, which can end up, if you give a medication, since there's more protein in their blood, then more of that medication is being bound by proteins. So whatever you're giving the medication for, it'll probably have a diminished effect because so much of it ends up being bound. And in a similar way, if say somebody has liver disease or renal disease and there's not as much protein, or maybe it's a malnutrition issue, if there's not as much protein in their blood, then the same dose of medication could actually become toxic because so little of it's bound. We're counting on some of it being bound, right? So that's just something to really think about with plasma protein binding. That's one of the biggest factors when thinking about drug distribution. So at any given time, it's only about 3 to 5% of drugs that are actually free to be therapeutic and then eliminated. So the vast majority of medication ends up being bound to protein. Some medications bind more highly than others. So NSAIDs would be one of those, antibiotics. Warfarin ends up being highly bound and can kick off other medications as well if they would have been bound. So thinking about how drugs are interacting with each other, that can have a factor. But especially for medications where there's a very narrow therapeutic window between it not having a good effect and being toxic, where we really need to keep a close eye on a tight window like that. For a drug like warfarin, that can make a really big difference if there are changes in plasma protein. So then just something to think about too, in order for a medication to pass the blood-brain barrier to be distributed, it needs to be highly lipophilic. So just something to keep in mind. Okay, so we've absorbed our drug, we've distributed it where it needs to be, and then the body needs to break it down and excrete it. So drug metabolism is the process of the body breaking it down so that the drug is in a form that it can be excreted. So not all drugs need to undergo biotransformation. Some of them are ready to just be excreted, but other ones will need to undergo some kind of a transformation so that they can leave the body. So if they undergo a transformation, that byproduct is called a metabolite. So I had my drug that was active, and then my liver broke it down, turned it into a metabolite that I can then pee out. So in a nutshell, that's what it looks like. Interestingly enough, though, some medications, it's not the form that you're initially taking that's active, it's the metabolite that's active. So you might take, like valcyclovir is a good example for that. That's one we give for women towards the end of pregnancy if they're at risk for developing genital warts. So you could give valcyclovir or acyclovir, but if you give valcyclovir, that would be considered a prodrug, meaning that the valcyclovir itself isn't doing anything, but once it's metabolized, its metabolite is acyclovir, and acyclovir is what's going to act on the body. So metabolites can be active or they can be inactive. The initial drug you take can be ready to go, or it might need to be metabolized before it can have a therapeutic effect. And then for metabolism, for drug metabolism, ultimately we need to end up having it in a water-soluble form because the vast majority of drugs are excreted by the kidneys. So they need to be water-soluble. So that's another thing. It might need to be transformed in order to become water-soluble so it can be excreted. So basically, the way drugs are metabolized are by cytochrome P40 enzymes. So there's a bunch of different ones, but think of it as that overarching category. Cytochrome P40 enzymes, that's what's going to break down drugs so that they can be excreted. So it's a family of enzymes responsible for the majority of drug metabolism. The majority of them are found in the liver, but they're also in the intestines, they're in the lungs, and other organs as well. So basically we're thinking about the liver, but other organs as well. And then when you're seeing it specifically spelled out which enzyme it is, it'll be designated as CYP, and then it'll have a number, a letter, and a number. So that's like saying this is my family, this is my subfamily, this is my particular identity. So that's how they're narrowed down. And there's basically just 6 of them. We've identified quite a few number of P40 enzymes, but it basically comes down to 6 of them that do the vast majority of drug metabolism. Okay, let's see, I think I had a few notes on this. Okay, I guess there's 57 enzymes, and then 6 of them are what's breaking down the drugs. If you were to consume something that inactivates or inhibits one of these enzymes, then drug levels are going to rise. And the opposite would also be true. You can increase the CYP metabolism with certain foods that you're taking, and then that can decrease plasma levels of the drug. Whether that's foods or medications, there's a lot of different ways that can happen. But different chemicals and drugs and foods can inhibit or induce this system. For example, chronic alcohol use, that would induce metabolism, whereas binging on alcohol tends to inhibit metabolism. So they would actually have the opposite effects. Great. Or like ciprofloxacin or influenza, those would both decrease enzymes. So if you're decreasing the enzymes, then it's not able to break down the drug as much, and then the drug starts building up in your system and can be toxic. So our job as prescribers would be to anticipate and manage different drug interactions. And this can help predict or explain individuals' responses as well. So I think this is really where pharmacogenomics comes in, is that for different subpopulations it can really affect their drug metabolism. So cytochrome P40 enzymes, that family of enzymes that help break down drugs, they're encoded on different alleles. So you might have one allele that's particularly good at producing this type of enzyme, and then if your other allele is also really good at that, then you as an individual would be very good at breaking down a drug, which means it would be broken down too quick for you to be able to have much of a therapeutic effect, and you might individually need a higher dose than somebody else, for example. But just looking through some of these differences here, so that's where the ultra-rapid metabolizer versus extensive metabolizer, that's kind of the middle ground, versus poor metabolizers. In the same way, if the two alleles that you have for certain enzymes are poor metabolizers, then if you're not breaking it down, the drug just keeps building up, and that can become toxic. Certain CYP activity is higher in women, and depending on like exactly which CYP you're talking about, and other ones are higher in men. So there can be sex differences for how different medications are metabolized, and then racial and ethnic differences as well. So for example, 7% of Caucasians are poor metabolizers of drugs dependent on the specific CYP, so CYP2D6. And CYP2D6 is important for breaking down beta blockers, opioids, and antidepressants. So if you're one of the 7% of Caucasians who's a poor metabolizer for the drug, then that would mean that those medications could be building up to toxic levels faster for you because you're not able to break it down. And similarly for Crestor, which is a statin, lower doses are often indicated for those from an Asian descent for the same reason. If you're not very good at breaking it down, then you might need a lower dose. So we've touched on this a little bit, but then we want to just be aware of drug-drug interactions, right? So they could interact in different ways. So maybe one drug makes it harder for another drug to be absorbed, or maybe it enhances the degree to which that drug is absorbed. In a similar way, enzyme inhibitors, so thinking about the P40 enzymes, cytochrome P40 enzymes, if it's an enzyme inhibitor, then drug A can inhibit the enzyme's activity and not allow the metabolism of drug B, so drug B builds up and that can be toxic. Or the opposite could be true if it's an enzyme inducer, then drug A can induce the enzyme activity and increase the metabolism of drug B, thereby decreasing the therapeutic effect of drug B. So they can interact that way. And then they can also compete for protein binding sites, which I alluded to earlier as well. So it's really about awareness. You might even choose to do some things intentionally to increase. The same could be true for drug-herb interactions. So part of what makes this tricky is that herbs aren't very well regulated, so there can be a wide dose variation. So you could take, if you take 100 milligrams of it from this brand versus 100 milligrams from that brand, there can be some pretty wide variation. So knowing exactly how much you're taking is trickier. Limited research having been conducted on herbs can lead to a limited understanding of what interactions there are. Some of the more common ones that are well known would be increased bleeding due to garlic, ginkgo, ginger, and ginseng. And then we also know that St. John's wort can decrease plasma levels of medications like warfarin, DIG, and midazolam. And then we know that foods can also have a big impact on affecting drugs as well. So thinking about the P40 system as well, grapefruit juice is probably our classic example that inhibits CYP3A in the intestines especially, and a lot of drugs need CYP3A in order to be metabolized. So the 3A is a subfamily, so you could see other numbers beyond CYP3A, such as 6 or 4, etc. But medications under that realm, I mean, there's a lot. Benzodiazepines, calcium channel blockers, antiarrhythmics, CNS depressants, immunosuppressants, statins. So if this is inhibited, then any of those drugs are going to start, are not going to be able to be metabolized, so they're going to build up in the system. We know that other citrus fruits don't tend to have the same effect, with the exception of limes and tangelos. Okay, and then we know that protein-rich foods that are high in tyramine, I'm sorry guys, my voice is having a hard time, tyramine, so thinking about like old cheeses, aged foods, fermented foods, pickled foods, smoked foods, all of those can affect, if within the presence of MAO inhibitors, can lead to hypertensive crisis. Be another classic example of drug-food interaction. Oop, we've already done that slide. Okay. So drug excretion. So this is all about taking those drug molecules and drug metabolites and removing them from the body. So primarily the kidneys, but it can also be removed in saliva, feces, sweat, mammary glands. So factors that affect the ease of excretion would be if they're low molecular weight, they're not protein bound, they're water soluble, and then their pH can also have an effect. And oftentimes that's going to change based on what the urine's pH is. So if the medication is a weak acid, then that'll be more easily excreted in more alkaline urine and vice versa. So clearance is the term we give for the body's ability to ultimately eliminate the drug, and that can have specific calculations around it, which we're not going to get into. But basically, just as a reminder here, so we can see that we've got our arteries are taking blood flow to our kidneys, so this would be the Bowman's capsule with the glomerulus. So then not at any given time, not all of it's going to be pushed out here, but some of it will get pushed out here, and if it does get pushed out here, it's in this tubule, and it needs to be able to get all the way through the tubules, down the loop of Henle, back again, and out the final collecting tubule in order to be excreted. So like, say it is more of a lipid-based drug metabolite, then it's going to be much more easily absorbed back into the bloodstream rather than staying in the collecting tubule and being excreted. So you have to get through all of those steps in order to excrete the drug. And then it's important when we think about medications that we have good renal function, because we need to have good renal function in order to ultimately eliminate the drug. If our kidneys aren't functioning well and we're not eliminating the drug, think especially about active metabolites, they're going to just continue to stay in the system and continue to have an effect. So serum creatinine can be drawn, and that's helpful. But it's hard to be able to get a really good, accurate depiction of what's going on, but it's at least a little bit of a good depiction, a good feel for what's going on. So 1.8 to 2.5 would be normal there. The creatinine clearance would be better, and that's basically taking an estimate at what our glomerular filtration rate is, and then actually assessing the glomerular filtration, or the rate of blood flow through the kidneys. So that would be our way to detect kidney health. That's what's recommended by the National Kidney Foundation. So most package inserts will still base dosing based off of creatinine clearance. So it's not as though you need to check this anytime you're going to give a medication, but if you're giving a medication that's particularly harmful to the kidneys and it's going to be in a higher dose or for a prolonged period, then it would be it would warrant checking into kidney function consistently if you're giving it for a prolonged period of time. Okay, so pharmacodynamics. We're done with pharmacokinetics. Again, pharmacokinetics are what our body does to the drug, and now pharmacodynamics are what drugs do to the body, which is basically the rest of the course, right? But just briefly to think about a few terms that help kind of frame how we think about pharmacodynamics. So it's the relationship between the concentration of a drug in the systemic circulation and then the response obtained. So potency, I think of as like our sensitivity of receptors to drug. So it's basically the concentration at which the drug elicits half of its maximal response. So we're starting to see a response. That would be its potency. Whereas its efficacy is the maximal response produced by the drug. And then within this framework, we want to think about having a therapeutic range or window. So plasma concentrations that produce the desired effect without toxicity. So we want enough of the drug that it's doing what we want it to do, but not so much of it we start getting too many side effects or having toxic effects. I like to basically say that all drugs are toxic, it's just a matter of the dosing. So needing to figure out our dosing appropriately. Okay, so pharmacodynamic concepts. We have drug agonists. So in this case, this would be a drug that finds a receptor and it causes an effect, ideally an effect that we're wanting, as opposed to a drug antagonist that finds a receptor and because it's found the receptor, there's no effect. So that can be competitive or it could be non-competitive, based on if there's something else in the body that's needing to attach to that instead, and that's the reason why there's not an effect. Okay, so partial agonists would be more just a subtle form of the regular drug agonist. So we have a suboptimal response if we're using it. And then affinity, we want to think about what is the attraction of a drug to a receptor. Is the drug more likely to find that spot? Is our own body's hormones more likely to find that receptor? And that can really affect what our dosing is. So if it doesn't have that high of an affinity, then probably the dose needs to be higher for that given medication. And then tolerance would be the word we use to think about if a receptor has started to lose its responsiveness. So when that drug is used, it doesn't work as well, which can happen over time with certain types of receptors. So here's a nice picture to go along with that. So here's our receptor site, and then this is before a drug. So this is our body's natural chemical. When it goes in line with it, we have this certain amount of cellular activity that happens as a result. So with an agonist medication, these natural chemicals could be hitting it, but then you could also have our agonist drug hitting it, and either way we have enhanced cellular activity because of that. So both are in play, and then we're getting more of a cellular response, as opposed to with antagonistic drugs. It's like they block it so that no cellular activity is happening if that's what's hit the receptor site. So I just wanted to show this graph as our last slide. So here we've taken the drug, and then this is the rate that we're absorbing the drug, and then this would be the peak efficacy, so time of maximum drug concentration, and then here's us metabolizing and subsequently eliminating the medication. So there is going to be a minimal effect concentration and a therapeutic range. So I wouldn't mind if this one had more lines on it, but let's say here's when we start to really notice it. So from here, this is our minimal effect concentration, and then maybe here's where we end therapeutic range. So anything lower than this, we're not having a therapeutic effect anymore. In which case you could also say that this here is our onset, duration, and termination of action when we're thinking about how a drug is effective in the body. And then if we were wanting this to reach a steady state, we're not just taking it once but wanting it to reach a steady state, then that's when we think about the half-life with repeated dosing, and then thinking about whatever that half-life is, somewhere in the 4 to 5 half-life realm. That's when we're going to hit our steady state. Alright, thanks for hanging in there with me, guys. And I'm very much looking forward to this semester, and I hope that future lectures I will not sound like a horse. Alright, have a good week.